Hello and welcome to the webinar, HIV/AIDS-related stigma among gay, bisexual, and other men who have sex with men. My name is Laura Bouchard, and I will be your webinar moderator today. Before I hand it over to our presenter, I have just a few housekeeping items to go over. The webinar is being offered by the Canadian Public Health Association, and our office is located on the original unceded territory of the Algonquin and Anishinaabe people. They have been the guardians of this land for millennia, and CPHA is grateful for the example their stewardship provides. This webinar is being provided as part of a webinar series that we've been hosting over the last several months, focused on the reduction of stigma associated with sexually transmitted and bloodborne infections. More information on this webinar series, including links to past webinars, can be found on CPHA's website at the link provided on the screen. And you can also connect with me or my colleague Rachel if you'd like further information on the webinar series. And our information will be provided at the end of the webinar. So hopefully you can hear me through either a headset or speakers on your computer. Due to the number of participants, we've disabled everyone's microphone. So I will certainly have some time at the end of the session for questions. We simply ask that you use the chat box to the right of your screen to pose any questions to today's presenters. And lastly, before we begin, just a quick note that today's session will be recorded and will be made available on CPHA's YouTube channel in the coming weeks. And if you're having any issues with audio throughout the webinar, you can use this chat box to let me know, and we'll try to sort you out. So today we're going to hear from Lauren Orser, who's also presenting on behalf of Patrick O'Byrne. And I'll provide you with a brief bio for both Patrick and Lauren, and then hand it over to Lauren to start the webinar. So Lauren Orser is a registered nurse for Ottawa Public Health with the Infectious Diseases Case Management Team, who specializes in HIV and syphilis follow-up. Lauren is also a Master's of Science in Nursing student at the University of Ottawa, and participates in research related to HIV prevention, sexually transmitted infections, and public health nursing. Patrick O'Byrne is an associate professor of nursing at the University of Ottawa. He is also a practicing nurse practitioner at the Sexual Health Clinic in Ottawa. His research and clinical practice focus on STI and HIV prevention, and his studies have included nurse-led HIV post and pre-exposure prophylaxis. He is an Ontario HIV Treatment Network Research Chair. So with that, I'll pass things over to Lauren for today's webinar.
Okay. Hi, everybody. Can everyone hear me okay? Yes. So thanks so much for joining today. So as Laura mentioned, I will be presenting on behalf of Dr. O'Byrne and myself. But if you do have questions for either of us, then, here we go. Our emails are both here, so you can feel free to contact either of us after the presentation, and the slides should be available in the next few days. So before we get started, I'd just like to start things off with question number 1 for the audience, just to see who's joining us today. So I apologize, this list isn't super complete, but just to get a sense of who's in the audience. Okay. All right. Okay. Lots of great people here. So lots of nurses. Oh. So we'll start things off by discussing what is stigma. So according to sociologist Irving Goffman, in society, individuals are categorized based on their possession of attributes thought to represent what is normal or ordinary for their membership within certain groups. This creates an unspoken expectation on the types of interactions we are likely to have with these persons. When we meet somebody for the first time, we subconsciously use our social training to anticipate a person's social identity based on their appearance and attributes. If this person is determined in our minds to possess typical characteristics of their group, our mind gives no additional thought. However, if this person is thought to possess certain physical, personal, and/or behavioral characteristics considered to be outside of what is socially desirable or normal, we reduce them in our minds to be a person who has a mark of tainted identity or as somebody who is abnormal. This labeling or reduction of identity is known as a stigma and refers to the possession of an attribute that serves to discredit an individual, which is used as the basis for social exclusion. So, building on this definition, in the case of HIV/AIDS stigma, the infection itself becomes a mark of spoiled identity or a sign of poor social character possessed by those living with HIV. The experience of HIV/AIDS stigma by persons living with HIV is often multidimensional and is categorized into three broad types. One, self-stigma, which are internalized feelings of blame, shame, and/or guilt over one's HIV status. Two, perceived or internalized stigma, which refers to the fear of being stigmatized if one discloses their HIV status. And three, enacted stigma, which is the experience of actual or perceived stigma. Enacted stigma generally arises from commonly held beliefs by the general population about the nature of HIV/AIDS infection and transmission, negative assumptions about individuals' risk practices and lifestyle, and fears of HIV infection, which can lead people living with HIV to become labeled and stereotyped in society on the basis of their serostatus. This in turn can lead to a loss of social identity and development of social discrimination. The ability to create such discrimination is based on social processes, which rely on the power to reproduce social inequality between stigmatized and non-stigmatized persons, or in this case, between HIV seropositive and HIV seronegative persons, which are based on social dynamics of power, culture, and difference. Gay, bisexual, and other men who have sex with men, or GBMSM, living with HIV/AIDS, often experience what is known as intersectional or layered stigmas, which relate to the discrediting of an individual's social identity based on 1, their belonging to a socially marginalized group, 2, engagement in HIV-related practices, and 3, their HIV serostatus. Stigmas can be affected by an individual's sexual identity or orientation, sexual practices, ethnicity, culture, age, or gender identity, and can be furthered by factors such as involvement in sex trade, survival sex, illicit substance use, etc. Thus, the stigmas experienced by people living with HIV/AIDS become layered upon other stigmas to create a total experience of stigma. So why is HIV/AIDS stigma so important to address? While HIV has become a chronic, manageable illness, the stigma associated with living with the infection continues to prevail in society. Results from the 2012 HIV/AIDS awareness study, which surveyed 2,000 people, showed that a number of Canadians hold negative perceptions about people living with HIV. As we can see here, nearly 1/4 were neutral or agreed that they were fearful of people living with HIV. Close to 10% agreed that persons who acquired HIV through sexual or substance-using practices were deserving of their diagnosis, and 5% expressed anger toward people living with HIV. What is most surprising in these results is that the proportion of Canadians who agreed with these statements has remained relatively unchanged over the past 10 years, and in some cases has actually increased. Now, because these statistics are a few years old, we thought it would be interesting just to open it up to question number 2 and ask, in your practice, how often do you encounter persons with negative beliefs about people living with HIV/AIDS? So for example, from other patients, colleagues, community members, etc. Okay. Okay. All right, so the never is promising, but It looks like, people are still continuing to see quite a bit of stigma in their practice, which is why it's important to continue to address. So as part of addressing stigma, we feel it's important to understand where HIV/AIDS stigma really originates from. So we provided here some perspectives about the social construction of HIV/AIDS stigma, resulting from the AIDS epidemic of 1981 to 1993, which was impacted by power differentials, specifically related to groups such as medicine, nursing, and religion, and sociocultural beliefs about same-sex lifestyles, which have contributed to the ways in which GBMSM, and in particular, men who have sex with men, are excluded in society. This type of social rejection can have a damaging impact on the physical and psychosocial health outcomes of GBMSM, and has had a lasting effect on how this group is accepted in society and how they may interact with the healthcare system. So to begin, we look at how the social construction of disease and sexuality, particularly among dominant social and professional groups such as medicine and nursing, shape the commonly held beliefs of AIDS and of men who have sex with men living with AIDS as being a threat to public safety. Such messages led men who have sex with men to be marked as having a spoiled identity and were promoted in mainstream society through the descriptions of AIDS as an alien invader and its association to a hard and fast death. During the AIDS epidemic, the general public grew fearful for the potential for contamination and started to separate themselves from men who have sex with men. These beliefs among the general public also affected perceptions among medicine and nursing. Specifically, medicine used pathology to differentiate normal from abnormal ailments and illnesses from diseases. For example, cancer was considered to be a normal medical illness, which evoked a certain degree of compassion from the general public for its unjust presentation in certain persons. AIDS, on the other hand, was considered to be an abnormal disease because it was brought on by reckless behaviors, or in this case, sexual practices of an immoral group, meaning men who have sex with men. Thus, medical diagnoses, which were presumed to be objective, may have been influenced by social perceptions of disease. In the case of the AIDS epidemic, men who have sex with men as an abnormal social group, living with AIDS as a sexually transmitted disease, were separated in society, which may have also affected how physicians and nurses treated their health needs, and may have contributed to the nearly 10-year delay in initiating trials for HIV treatment. So the next point, disease as punishment, discusses how men who have sex with men were marginalized in society by social power structures during the AIDS epidemic. In these views, men who have sex with men were seen as deserving of disease because of their immoral sexual desires and sinful lifestyles. The deviant sexual behaviors, for example, frequenting bathhouses, engaging in anal sex, having anonymous sexual partners, illicit drug use, and desires for male sex among men who have sex with men, were viewed in society as sins. As such, the hardships of men who have sex with men who are combating AIDS were considered by the general public to be a fitting retribution. These beliefs were also promoted by Christianity, who viewed heterosexuality as the right way to live, and healthcare, which promoted abstinence and monogamy as a means to achieve good health outcomes. Together, these groups use their combined powers to segregate men who have sex with men based on their sexual practices. Moreover, the AIDS epidemic shares a historical association between the outbreaks of syphilis and gonorrhea in the 1800s and 1900s. The unnatural sexual transmission of these infections was considered to be a sign of bad behavior, and so the efforts of healthcare and the church during this period promoted self-control as a means to reduce ongoing transmission of infection. During the AIDS epidemic, men who have sex with men were subjected to similar attempts for sexual reform, which preyed on their vulnerabilities for social and religious acceptance, and ultimately led them to be stigmatized in society for their inability to improve their behavior. So social exclusion based on sexuality and gender factors relates to assumptions of male gender roles in a term developed by Brian Connell known as hegemonic masculinity. In this view, gay, bisexual, and other men who have sex with men become stigmatized in society based on their failure to meet pre-established social expectations of masculine behavior, appropriate male decorum, and acceptable sexual rules. Specifically, during the AIDS epidemic and continuing today, men who have sex with men were seen as weak and vulnerable compared to their heterosexual male counterparts, which serves to reinforce social gender norms and orders, and thus exclude men who have sex with men. So combating HIV/AIDS stigma has been raised in Canadian and international frameworks, with the Federal Initiative to Address HIV/AIDS in Canada, the Canadian Foundation for AIDS Research, and the United Nations AIDS, all citing stigma reduction as a top priority. These initiatives are important because while long-term health outcomes living with HIV have improved, many of the social perceptions have not. As such, GBMSM living with HIV continue to experience stigma in a number of social, professional, and healthcare interactions. So before going into the significance of stigma reduction, we'll open it up to question number 3 and ask, where do you feel stigma is most likely to be encountered by persons living with HIV/AIDS? It's not really a right or wrong answer, just looking to see what your perspectives are. Okay, yeah, so we would say the same thing. So pretty much all of the above. Stigma can be encountered in a number of different ways and settings, from an offsite comment by a peer or colleague, to a disapproving look or tone by a healthcare provider, to outright rejection by a sexual partner following HIV disclosure. In addition to the experience of actual stigmas, GBMSM living with HIV can often internalize the stigmas they experience or that they anticipate they might experience, which can lead to the development of a negative self-image. GBMSM living with HIV may also fear that they will be judged, shamed, or discriminated against if their HIV status is revealed during social interactions or during healthcare visits, and thus they may begin to avoid situations in which they would have to reveal their status to others. The outcomes of this internalized stigma can lead to 1, issues with chronic health, meaning reduced physical health, decreased quality of life, or increased morbidity and mortality living with HIV/AIDS. 2, issues with mental health or substance use, such as depression, anxiety, or increased use of illicit substances, which for MSM in particular relate to the use of opiates, benzodiazepines, cocaine, and methamphetamines. 3, social isolation, so the avoidance of friends, peers, or sexual intimacy due to fears of HIV disclosure, concerns about others witnessing their pill-taking behaviors, or unwanted questions about their health. And 4, healthcare avoidance. So persons may start to avoid accessing preventive healthcare visits related to their HIV care, to general health screening, or for sexual health assessments, for fear they will be judged, asked invasive questions, or in some cases sort of made to feel like a criminal for engaging in sexual contact while living with HIV. This in turn can lead to poor health outcomes related to HIV, particularly for GBMSM who are struggling to cope with their HIV diagnosis or who have concurrent or mental health or addictions issues. which may prevent them from participating in healthcare decision-making, completing routine HIV follow-ups, or taking their HIV treatment as prescribed. The points raised about internalized HIV/AIDS stigma are actualized here, with results from the People Living with HIV/AIDS Stigma Survey, which was done in 2015 out of the United Kingdom. This demonstrates that a number of HIV-positive persons do in fact fear the possibility of experiencing stigma, and that's represented here in the pinkish reddish bars, which can lead such patients to either avoid seeking care, delay initiating HIV treatment, or feel like their care was refused altogether. So given the realities of HIV/AIDS stigma and the possibility of negative health outcomes for GBMSM, we'll now review some strategies to use while working with persons living with or at risk of HIV/AIDS, and then move into our preferred approach with examples from our own practice as nurses in a local STI clinic. So the first point in reducing stigma relates to being mindful of the language and terminology we use, both when writing about and in conversation with GBMSM. So these points here are adapted from the Let's Stop HIV Together campaign, which was released by the Centers for Disease Control and Prevention out of the US. So in writing, the term unprotected sex is often used to refer to sex without a condom. However, this term can be potentially stigmatizing, as it might imply that patients have a total disregard for safer sex, when in fact, HIV seropositive persons using HIV treatment or seronegative persons using PrEP are actually having protected sex. It is just that they are only protected against HIV. Instead, we suggest the use of terms like sex without a condom or condomless sex as more precise ways to refer to sexual encounters where a condom was not specifically used. In addition, the term high-risk group is commonly used in writing to refer to GBMSM as a population group with increased incidence of HIV infection. However, this term might imply that membership within this group can result in increased risk for HIV acquisition, and thus may provide a false sense of security to those who do not self-identify as gay, bisexual, or other men who have sex with men. Instead, we recommend the use of terms such as high-risk behavior, key population, persons at higher or greater risk, or highly affected communities when referring to risk practices and incidents among GBMSM. It's also important for providers to consider the potential to perpetuate stigma in conversation with GBMSM, regardless of the person's HIV status. In particular, terms like infected or contaminated bring an association of viremia, which can serve to negatively define people living with HIV by their health condition alone. Similarly, terms like sick, victims, or sufferers can reduce power among seropositive GBMSM and can segregate people living with HIV. Next, when discussing HIV transmission, the general use of the term body fluids might imply that any contact with people living with HIV could transmit the infection. As such, we feel it's important to be factual when providing sexual health education about HIV or STI transmission risks by specifically referring to the mode of transmission as blood, semen, pre-ejaculate, vaginal fluid, and/or rectal fluid. In addition, terms like HIV or AIDS patient or HIV infected implies that persons living with HIV are in a constant state of illness, which, as we are aware, should not be used to define a person as a whole. Instead, you should consider the phrase person living with HIV or AIDS. And finally, it's important to be mindful of the use of phrases such as to catch HIV, to pass on HIV, or to discuss HIV or really any STI as being contagious. This is because HIV cannot be passed or caught and it's not contagious like a plague. It is transmitted. Instead, we suggest using terms like diagnosed with HIV, acquired HIV, or transmission of HIV or other STIs. So sexual health and risk reduction counseling can be an important opportunity for clinicians and community workers to provide practical information and resources to patients on how to decrease their risk of HIV and other sexually transmitted infections. However, it's important for providers to ensure that these messages are delivered to patients in a sex-positive way. Overall, GBMSM, regardless of their HIV status, are aware of the risks and benefits of using condoms. However, the fact of the matter is that some prefer not or cannot always use condoms during sex. So if you'll pull it up to question number 4, we'll just do a quick poll of the audience to see what you think the self-reported rates of condom use are. Okay, yeah, so the answer is about 45 to 60% of all patient groups report consistent condom use during sex, with results from Statistic Canada showing that self-reports of condom use have actually increased in the last few years, particularly among those who identify as male. Yes, sorry, Sarah, I did see your comment there about breast milk. That is a transmission mode, you're right. I just didn't include it in this because we were talking specifically about GBMSM, but that is a good point, thank you. So reasons for lack of condom use during sexual encounters may relate to personal preferences about condom use. For example, decreased sensation or inability to maintain erections, challenges with accessing free condoms. So particularly for patients who live in rural or remote areas. Getting sort of lost in moments of sexual intensity or pleasure and forgetting to put a condom on, or not always having a condom readily available. And sexual pleasure or arousal that persons may experience from ejaculate or from semen exchange. Lack of condom use can also relate to scenarios such as condom failure, so where the condom slipped, fell off, or broke, or where condoms were used and intentionally removed by a sexual partner without the individual being aware. As such, it is important to avoid placing blame on a patient when they disclose condomless sex, and to remember that sex without a condom does not mean that patients have a disregard for their health. For example, promoting condoms as the only way to avoid HIV or other STIs, or inferring that a lack of condom use will always lead to new diagnoses or the potential for HIV, may not be the most effective way to build trust with patients or to promote positive safe sex messages. Such messages may actually serve to sort of further feelings of internalized guilt or shame among HIV positive GBMSM, who may have identified condomless sex as a risk factor for their HIV diagnosis. This could also lead GBMSM in general to avoid seeking STI or HIV testing in the future if they continue to engage in condomless sex for fear of being judged by their provider, and thus may become a barrier to their engaging in care. So while condoms are part of the component of safe sex messaging, they're not the only strategy that patients can use to reduce their risks. And these are points that we'll sort of get into a little bit more now. So building on these points, we'll now overview some strategies from our practice working with both HIV seropositive and seronegative GBMSM in an STI clinic in Ottawa. Beginning with our clinical assessment of HIV seropositive GBMSM. So in our approach, we use 4 questions seen in the table here related to patients' HIV management and care to structure STI screening, testing, and assessment visits. These questions are asked to all HIV seropositive patients at all STI visits and were instituted in our clinic as standard assessment, one, because such questions relate to the clinical management of HIV-positive patients diagnosed with syphilis, as patients with a lower CD4 or immune system count may require a referral or an assessment by an infectious disease specialist. And two, to help identify patients who might be having challenges with HIV management or care, and to help link such persons to necessary supports. Risk assessment questions also help identify relevant STI testing and vaccinations patient might require, and to provide such patients with safer sex and harm reduction materials as needed. The use of an approach such as this also relates to findings from qualitative studies conducted in Ottawa by Dr. O'Byrne, which found that many GBMSM living with HIV note that their healthcare provider will ask about their HIV status during health visits, and upon learning they're positive, not really know how to proceed with the information. As such, the assessment points detailed here could be a means of reducing HIV-related stigmas for seropositive GBMSM who are accessing STI testing by giving a consistent approach to care. HIV seronegative GBMSM can also experience HIV/AIDS-related stigmas due to their belonging to a population group at higher risk for HIV, when in fact, some individuals who identify as gay or bisexual might not always be acting as the insertive partner, they might only be engaging in oral sex, or they may not be having any sexual contact at all. As such, our approach to the assessment of seronegative GBMSM follows a similar model to the one presented. The counseling provided to patients is based on their identified risk at the point of visit, not on our assumption of risks based on their group membership. This includes assessment of sexual and substance using practices, which could put GBMSM at increased risk for HIV acquisition, recommendations for routine STBBI screening, for example, every 3 to 6 months, depending on identified risks, the rationale for which is that screening and testing for HIV and other STIs, like rectal chlamydia or gonorrhea, herpes simplex type 2, and infectious syphilis, can all facilitate HIV transmission, and thus are important tests to reduce ongoing potential for HIV. We also considered the distribution of safer sex and harm reduction materials, such as free condoms, needles, and other drug use paraphernalia, and counseling and information on HIV prevention strategies, such as post-exposure prophylaxis, or PEP, which is provided in our clinic by registered nurses under medical directives, and pre-exposure prophylaxis, or PrEP, which we will detail a little bit more now. So the Canadian PEP and PrEP guidelines recommend that PrEP be offered to all men who have sex with men, reporting condomless receptive anal sex in the past 6 months. Among their indications for PrEP use for MSM is an HIV incidence risk index, or HIRI score, greater than or equal to 11 points, which is pictured here. This calculates risk based on a person's age, number of sexual partners, sex with HIV-positive partners, and to note that this is regardless of whether or not this partner is on HIV treatment or is virally suppressed, their engagement in receptive anal sex, and substance use, including methamphetamines or poppers. What is problematic with this criterion is that if you are a male between 18 and 48 years of age and have had receptive anal sex even one time in the past 6 months, then you are considered to have high-risk behaviors and thus are in need of PrEP. The use of a scoring index such as this can be potentially stigmatizing to both HIV seropositive GBMSM, as this score assumes that any sexual contact with them is higher risk, as well as HIV seronegative GBMSM. As a large subset of this group, even with one instance of receptive anal sex, are considered to be higher risk. So to reduce potential stigmatization of GBMSM and labeling of all persons in this group as higher risk, our approach to PrEP delivery is based on the identification of persons with objective indicators of risk. Specifically, we suggest PrEP be offered to persons who have 2 or more diagnoses of rectal chlamydia and/or gonorrhea in the past 12 months, persons diagnosed with infectious syphilis, meaning primary, secondary, or early latent, known HIV contacts, which in our setting are limited to persons whose sexual partners were diagnosed with HIV in the past year and who were specifically notified by HIV case managers, and persons with a single HIV PEP use, which differs from the Canadian PrEP guideline recommendations of 2 or more instances, because data from our PEP trials found that 10% of all men who have sex with men became HIV positive within 1 year after PEP use, following a new exposure or subsequent exposure to HIV. This model here has actually been implemented in our clinical setting, where patients who meet any of these criteria are offered PrEP referrals through our STI clinic, as well as by public health nurses doing ST-BBI case management. We feel that such an approach can be useful in reducing stigma among GBMSM simply because they belong to a group at higher risk for HIV infection. This is a point that applies to all priority groups in Canada, including GBMSM, persons who use injection drugs, African, Caribbean, and Black persons, transgendered persons, and some Indigenous groups. In terms of offering PrEP, it becomes a delicate balance between potentially stigmatizing an entire group based on their collective risk and ignoring them and potentially letting them suffer. The answer is therefore not to dismiss the potential for HIV risk, but rather to make appropriate assessments which consider both individual and group level factors. So the framework here is a risk matrix that we developed, which can be a useful tool in making assessments of patients' need for PrEP. And this is actually from an article released earlier this week in the Canadian Journal of Human Sexuality, which is available open access. In our STI clinic, we recently piloted the first nurse-led PrEP clinic in Canada, which was led by Dr. O'Byrne and a team of nursing researchers and HIV experts in partnership between the University of Ottawa and Ottawa Public Health, and with funding from the Ontario HIV Treatment Network. So this initiative aims to provide expedited access to PrEP care to those individuals who meet our high-risk behavior criteria, to reduce barriers to PrEP access, and to reduce healthcare costs associated with PrEP by having registered nurses perform all PrEP-related testing and care under medical directives from nurse practitioners. In addition, this model of PrEP delivery uses nurses with expertise in sexual health and HIV prevention, and thus may be a less stigmatizing approach to PrEP delivery. In our setting in particular, patients accessing HIV and STI testing will often see the same providers for PrEP care, which adds to consistency of visits and could increase patients' overall comfort level in obtaining such care. As part of PrEP RN, nurses also screen patients for mental health and addictions issues using validated depression, anxiety, and drug and alcohol assessment tools, and make linkages to appropriate services in the community for those with identified needs. So in sort of wrapping things up, we just wanted to touch base on some of the points to address the structural drivers of HIV/AIDS stigma for GBMSM living with HIV. So structural drivers of HIV/AIDS stigma refer to policies, laws, and politics which disadvantage GBMSM. For example, in Canada, we have one of the highest rates of prosecutions related to HIV non-disclosure in the world, with at least 184 persons having been charged with criminal offenses for allegedly failing to disclose their HIV status. While great strides have been made with the recent release of the federal directives related to prosecutions of HIV non-disclosure announced in December 2018, more work is required to ensure that GBMSM living with HIV have sufficient access and opportunities to meet optimal care outcomes. For example, clinics with specific mandates around STD-BI testing often focus on preventive HIV screening and might be less equipped in identifying those patients who are already diagnosed with HIV and who may be facing barriers to HIV care. This has the potential to create stigma among persons living with HIV if they feel that their health needs are perhaps not as important as those who are HIV negative, and may lead these individuals to avoid discussing barriers to HIV care in the future if their experience doing so in the past made them feel like no action had been taken, and may disadvantage these individuals if they have a subsequent negative interaction with public health units or with the criminal system. In addition, public health units, healthcare providers, and community workers alike need to reconsider their use of a one-size-fits-all approach to HIV management by examining some of the syndemic barriers GBMSM might face in achieving optimal care living with HIV, and by strengthening community collaboration to help these patients meet their individual healthcare goals. Recent campaigns promoting an undetectable viral load equaling untransmittable HIV, or U equals U, have been raised throughout North America as an efficacious HIV prevention strategy, and could also be beneficial in reducing the experience of stigma among persons living with HIV who are engaged in HIV care and who have successful treatment outcomes, specifically with a sustained viral load under 40 copies per milliliter. This has led to the subsequent adoption of U equals U by a number of healthcare providers, community agencies, and public health organizations. Now, while this is very important work in combating HIV/AIDS-related stigmas, it is important to be cognizant of the potential for U equals U messages to generate new stigma among GBMSM living with HIV, specifically in terms of its potential to create hierarchies in HIV treatment successes among HIV-positive men. Yes, good point. For example, individuals who are experiencing barriers to optimal care may fear the potential for stigma for peers, sexual partners, and/or healthcare workers if they are having difficulties maintaining an undetectable viral load. For example, due to mental health or addictions issues, financial issues paying for medications, etc. As such, we feel that a U equals U approach is important. However, we feel that such an approach should be used to assist, not dismiss those who are experiencing challenges with HIV treatment and care. The takeaway message here is that all professional groups working with GBMSM living with HIV should use a bottom-up approach to combating stigma, being mindful of language, using a sex-positive approach to counseling, and tailoring of risk assessments of both HIV seropositive and seronegative individuals to actual, not perceived risk factors. In addition, it's important to build effective partnerships within the community, from GBMSM Wellness Group to AIDS Service Organization to HIV social workers, physicians, nurses, pharmacists, and to increase outreach initiatives to assist those living with HIV in meeting their personal health goals. As well, we feel it's important to include GBMSM living with HIV in the design, development, and implementation of new programs and initiatives, as the effectiveness of such interventions are only useful if they incorporate those who they are targeted for. Okay, so that's all we have for you today. So we can take it to some questions. I'll pass it over to Laura, I guess.
Yeah, great.
And just to...
Oh, sorry. Go ahead, Lauren.
Okay. I think you said that the slides will be available in the next few days. So we'll circulate those as soon as we can. And just to know that some of the articles we referred to there, most of them should be available actually open access. So if anyone's interested in looking at those a little bit further, the links will be with the slides.
Okay, that's great. Yeah, so thank you so much for that really informative presentation. And we do have some time now for questions. So you're welcome to use the chat box there on the right-hand side to share your questions. And just to note that these questions will be shared with all of today's webinar participants. So yeah, I'll give you a moment to type in some questions if you have them and let Lauren speak to those.
I noticed there, Randy had pointed out that U equals U also speaks to a third U, indicating universal access to care, treatment, and strategies for adherence issues. And I think that's a really good point. I actually hadn't heard of the sort of third U there, so I think that's a really great message to communicate around.
Okay, so Randy says, I sit on the International Steering Committee for U equals U, and you'll see more about this third U in the coming week. So that's really great.
Fantastic work, yeah. Great.
Okay, were there any other questions we can hold on the line for? If anyone has any questions they'd like to type in, otherwise we'll close things up.
And our emails are there, so if you do have questions that you think of later, feel free to message Patrick or I.
Okay.
Thank you so much. Thanks for joining, everybody.
Great. So before closing, I'd just like to ask you to please take a minute to fill out CPHA's anonymous evaluation survey for this webinar. So your feedback will be used to help us improve future webinars. And the survey should open when you exit the webinar platform, or you can use this link on the screen to take you to the survey. And as was also mentioned, the webinar recording will be made available on CPHA's YouTube channel in the next few weeks. And lastly, you can find out more about CPHA's webinar series, as well as CPHA's resources related to reducing STD-related stigma at our website, or you can contact myself. My email's on there, Rachel's is, so you can contact myself or Rachel at CPHA directly if you have any questions about CPHA's stigma work. So yeah, with that, I'd just like to say thanks again to our presenters, and thank you all for being here with us today, and have a great day.
Bye.